Another high-risk fracture that we see around the midfoot is the navicular fracture. And the way that we can locate the navicular most easily is to find the tuberosity on the medial side of the foot. Now, on some runners, it's quite prominent and easy to find. In this person here, it's not as obvious. So we locate the tuberosity, we move dorsally, and it's around this region, just in front of the ankle, where patients often present with pain if they have a navicular stress fracture. It's known as the end spot. It's typically in the central aspect of the navicular, not the medial or the lateral, and we get pain with direct compression. It can be confused with anterior impingement syndrome or impingement of the ankle, so it can be difficult to diagnose. It often gets misdiagnosed, and for that reason, it often has a delayed diagnosis.
Any tips there with the navicular?
Not really. The only tip I would suggest is anyone who's presenting with medial ankle pain, always have that in the back of your mind. I've seen a few navicular fractures that have actually coexisted with an anterior impingement syndrome as well. And there was a time there where if you went in for surgical repair of a navicular, they're also scoping the front of the ankle because a reduced ankle dorsiflexion was thought to contribute to the load on the navicular joint. Whether it was simply, because you don't have enough motion at the ankle, it's just simply being demanded of the next joint down, and that puts stress on the navicular. It might have been the school of thought, but they can go hand in hand. There was some early work published by Peter Bruckner that also found that a lack of ankle dorsiflexion is a risk factor for navicular stress fractures. So if someone's presenting with anterior impingement syndrome, or potentially in the back of your mind you're thinking navicular, I treat it like an anterior impingement syndrome early, but be very alert that it might not be if it doesn't clear with, say, ankle mobilisation, for example, or maybe a heel lift to unjam the front of the ankle. I have an interesting story to tell you about navicular fracture. I think it's interesting. We had a footballer, so not a runner, a footballer who presented with what looked like anterior impingement syndrome, and went off for a scan, and there was some bony oedema in the navicular and also what appeared to be a fracture line. Went for a CT scan, it came back clear. So this is unusual. We'd already booked him in for surgery or surgical opinion. Gone back and looked at that MRI and observed it wasn't actually a fracture. It just happened to be a nutrient artery running through the navicular that appeared to be a fracture. It just so happened that there was some bone stress in the background anyway. There was actually a stress reaction. So the management went from, he's probably going to have surgery and ankle scope and all the rest, to actually no, it's just bone stress, unload it in a cam boot for 4 to 6 weeks and it'll settle down. So two very different scenarios, purely based on, I guess, interpretation of some imaging, and knowing that sometimes you can get a stress reaction occurring around a nutrient artery in a bone, or just there is those little red herrings every now and then.
Yeah, and clinically, did you say they were presenting like the history was making you think navicular, or you definitely thought that this is ankle issue?
No, it did present, well, it presented as ankle, but often that impingement at the ankle can often be a navicular fracture. The thing with navicular fractures is they're not overly painful. So even though they might be considered a high risk fracture, and no one wants a navicular fracture because they've got a bad reputation, it's not because they're painful. That's why they have this delayed diagnosis, and that's why a lot of people turn up and it's a really deep fracture, and that's why often they need surgery. So you really want to pounce on them early if you can, so that if there is a breach of the cortex, it's not extending through the body of the navicular and there's minimal risk of it breaking down over time. So early diagnosis is key.
Yeah, it makes sense.
If someone is presenting with dorsal medial foot pain, it's important to eliminate a tibialis anterior tendinopathy, an extensor lucis longus tendinopathy, or even a extensor digitorum longus tendinopathy. So muscle testing can be quite useful in this setting. So here I'm going to stabilise the rear foot. I'll apply pressure on the forefoot and I'll ask the patient to pull their foot back towards them. And as they're dorsiflexing, I can see the tibialis anterior is quite prominent. Here's an opportunity to palpate that tendon and see if it can reproduce the patient's symptoms. If they had a navicular fracture, this should not hurt them. However, if you can reproduce pain, then I'm starting to think it's more of a tendinopathy. The same can be said about the EHL. So I'll have the patient dorsiflex their hallux. Here we can see the tendon's quite prominent. I'll use my thumb to palpate along that tendon, trying to avoid compression of the navicular, and we'll repeat the same with the extensor digitorum longus, which is slightly lateral, so it's less likely to be the cause of dorsal